arthroplasty section of the trauma course. We've got a very interesting little program this morning. We have to keep on time because there's a huge topics to cover. So we're going to do about 12 minutes per presentation and time for a couple of questions. We're going to be starting off with Allan van Zyl, who you all know very well. He's going to be talking to us about the acetabular side of things. Thanks, Allan.
My talk is on total hip replacement after acetabular fractures. Acetabular fractures make out only 3% of all the fractures that we'll see coming through our emergency rooms. These acetabular fractures will have between 50 and 80% short-term complications. It depends on the amount of energy that goes through developing this fracture, the immobilization, and also the surgery. The long-term complications, however, are more dependent on the type of fracture that we see. The late onset of osteoarthritis can be as high as just about 60% in these fractures. Also dependent on the type of fracture, the magnitude of force, imperfect reductions, and also chondral injuries, especially on the femoral head. The delay of treatment of these fractures has an effect on arthritis, pre-existing arthritis, interarticular hardware, infections that can develop, and also age and weight of the patient. In some papers from Dunay on conversion to total hip arthroplasty, his figures are about 35% at 10 years post-injury. What is interesting is the time to conversion to total hip replacement is actually early. It's less than 4 years. Others have got a little bit longer figures from Romnek. Also, the male-female ratio is 3 to 1. 3 times more males will be converted to total hip arthroplasties than females. And they stress the bipolar injury, in other words, the injury to the femoral head, being the most important in converting these to total hip arthroplasties. What's also always comes out is that irrespective of what you do, you'll always have inferior results with a total hip arthroplasty after a fracture than with osteoarthritis. If you look at this paper there, Kaplan-Meier's survival curve for arthroplasty fractures, you can see there's a dramatic drop-off in the first 3 to 4 years after fixation of those fractures, that they will be converted to hip replacement, and then a sort of steady decline over the years. So the important is those early years. How many of these will you see in your practice? I've looked at my figures. From my database, about 20 years, 2,700 hip replacements. I've only seen 37 of those had a previous acetabular fractures, which means a low incidence, 1.4% that I've seen in my practice. So you're not going to see a lot of these coming your way. The increased failures you'll see, which possibly is an argument for acute reconstruction of these fractures to total hip replacement. As the age increases, you'll have more failures. As I said, femoral head cartilage damage, you have more failures, osteopenia, the superior and medium dome impaction, and then also posterior column involvement. And CREDA actually says that in patients above the age of 50 with marginal impaction or comminuted dome, is actually above 50% of these will be converted to total hip arthroplasty. The options, treatment options in the elderly, and most of these will be converted to total hip arthroplasty. We can't forget hip arthrodesis, although it's getting less and less as the years pass. Pre-operative planning is important if you want to do these cases. Always think of the possibility of infection, and the normal workup is essential. You need the normal x-rays and perhaps a few other things like CT scans and so on to get your mind around what you have to do. You have to get all the total hip arthroplasty components and perhaps a couple extras like cages and also the instruments for open reduction and internal fixation, and have graft available. The problems that can occur with converting these to total hip, when we convert to total hip arthroplasty, we'll run through them. Young patients, the nerve damages, the internal fixation devices, infection, avascular necrosis, which is high on the bone on the acetabular side, scar tissues, and heterotropic ossification. I'll not go into all of those. One of those is the young patient. They definitely have inferior results if you compare the results of their hip arthroplasty to degenerative arthritis, and this is mostly on the acetabular side where you'll see acetabular loosening. It would seem from the literature there's no real big difference between the type of prosthesis that is used in these cases, cemented, uncemented, the bearing surfaces, or resurfacings. Other problem is nerve damage. Now, we often see these patients coming in with pre-existing nerve damage that happened during the primary injury. It can happen during fixation of these fractures, and then with the third hit, following the joint replacement arthroplasty, you can damage the nerves with the scarring around that area. And it's a good idea to identify the nerves in the sciatic nerve when doing these. And very important is to inform patients of the possibility of nerve damage and document that. The problems of internal fixation, you really have difficulty removing these prior to your hip arthroplasty. It's probably not advisable. And some cases you can only remove the interarticular portions of a screw, and for this you need Midas Rex and Almsbach handy to do these. This is a simple little case, two screws, one is broken. To remove those are easy and converted very easily to a total hip arthroplasty. This is a little bit more difficult with anterior and posterior screws and plates that have been placed. And for these, you can leave most of that just intact and go on and do your normal joint and just remove the interarticular screws that you come by when reaming that acetabulum. Expect non-unions. These can be fixed with screws, plates, cages, multiple hold cups, and also grafting is important. A couple of these cases, this is a 3-month delay in diagnosis with pelvic discontinuity. This is a case of 20 years ago that I did, that I opted to do a 2-stage reconstruction, fixing the acetabular with a Gons cage and also grafting, and then 2 months later going on to do your total hip arthroplasty, and this worked very well for the remaining of this gentleman's years. Probably do it differently today. This is also a innocuous little case. Doesn't look like anything big, but when we got in there, there was pelvic discontinuity, and we got around that by doing an internal fixation within the acetabulum with the plates, and grafting with a sloof technique and a cemented cup on top of that. Bone defects, these, if they are contained, bone impaction grafting is always good. Uncontained defects need to be contained with some sort of a plate or mesh and then bone grafted. And some of these will need structural bone grafting and augmented with cages or trabecular metals. This is one such case with a high hip center had gone right up there, and this was grafted the stereo acetabulum and the hip put into the true acetabulum. So grafting is important also with these type of cases where you can graft and put a cage on. The outcomes, looking at outcomes and survivors, once again to stress, you will always have inferior results doing hip replacements in these cases compared to your osteoarthritics. They'll have inferior survivorship and inferior results if you look at the Harris hip score. What is important to all these cases should have some sort of bone grafting, and if you do that, you'll probably have results of survivorship very close to primary osteoarthritis. And once again, you've got options of bone grafting with a cemented cup like Sloof, or with uncemented cups, which has been reported by Berry. Acute stabilization and total hip arthroplasty, this is something that I have very little knowledge about, and I haven't done them, but it is out there, and you can stabilize with plates or cables even, and then do your hip replacement on top of them, also with these delayed and misdiagnoses as been described by Coventry. These aren't my x-rays. This is a typical old patient with an anterior column with a displaced quadrilateral plate. That's what the CT scan looks like. This was fixed in that manner, and then directly after that went on and the hip replacement was done. I can just imagine looking at possible complications by doing these things. Another of these cases from the literature, also anterior column, and they opted to use a cage and a bone grafting to do these cases. However, these aren't dissimilar to the cases that we often see with pelvic discontinuity when we do revisions. And I think this type of construct with a trabecular metal cup cage and a cemented component on top of that would work well, as we've done in this case. In conclusion, Mr. Chairman, these hip replacements after acetabular fractures, they can be difficult to treat, and one must recognize that. You need a lot of pre-op planning, get the right instruments there. Bone grafting, it would say, is very essential. And then you can have satisfying, although these are guarded results in these patients. Thank you very much.
Thanks, Al. Yeah, I always find one of the biggest problems are is there a non-union or isn't there? And I think the CT 3D reconstructions are really helpful.
Yeah.
And I do them routinely on these acetabular cases. Quite often you get in there and you find that there's just a little bit of movement there, and those cups are really going to be in trouble if you don't have the proper stuff to fix them with.
Yeah, I think the newer cups that are available where you can put multiple screws in all over and graft that area, it's actually a little bit easier these days than what we had many years ago.
Yeah, I think that trabecular metal augments foot plates are really helpful in these ones.
Yeah.
Allan, thank you for an excellent overview. My question is, I see you aspirate all of your patients. If you get a positive culture back, what do you do? How do you handle that? Give him intravenous antibiotic? When will you re-aspirate him again? Or when will you put your definitive prosthesis in?
I think if you get a positive culture, I've certainly had these cases. You must do it. I do a two-stage revision. Yeah, I'll leave the patient with the girdle stone, take everything out, take the metalware out, debride everything, and put your antibiotic cemented spaces in for that period of time. One must think of these. Often these things are complicated with low-grade infection around plates and screws.
Thank you, Allan.